Alright, my name is Miriam. I am a student physical therapist assistant with Owens Community College, and today we're just going to be assessing dermatomes and myotomes with our patient. When testing these, you want to make sure that you are hitting both extremities, both the affected and unaffected sides, so you can better compare those abnormalities, weaknesses in one side versus the other. So, getting started, we will want to be testing the myotome C5, which is your deltoid muscle, which works on shoulder flexion and abduction. So you'll have your patient bring their arms out to 90 degrees like so, and then you're going to push down and have them resist that pressure. Perfect. And then next you have C5 and C6, which is working on elbow flexion and wrist extension. This you will have your patient have their arms supinated at 90 degrees, and you're going to press down on their forearm, testing their bicep muscle. And then opposing that would be C7, which is elbow extension. In that same position, you are going to try and flex their elbows and having the patient resist that. Perfect. All right, next for cranial nerve 8, we have ulnar deviation. To do this, we want their arm to be side-lying like so, and then ask patient to resist that abduction. So you are going to push up on their thumb while they are trying to bring that thumb to their pinky, like so. Good. And then next we have T1, which having these last 3 fingers just kind of secured like so. We are going to work on AD and abduction of this index finger, so having them oppose your resistance one way and the other way. Perfect. Alright, next we're working L2, L3, and L4, which is going to be the quads firing to achieve knee extension. So for this one, you're going to push down on your patient like so, having them try to extend their knee as much as possible. Go ahead and do that for me. Perfect. And as always, again, testing both sides. Nice. Next then, we have L4 with ankle dorsiflexion. So for this one, you're going to instruct your patient to bring nose to their toes, as well as pushing down on their foot like so. Go ahead and do that. Perfect. Testing the other one as well. Nicely done. And then next is going to be L5, which is testing your extensor hallucis longus, which is going to be the extension of your big toe here. Have them bring that to their nose, pushing down on that big toe. Wonderful. Opposite side as well. You can do that. Great. And then finally we have S1, which if you stand on up, that is going to be plantar flexion of your ankle, testing your gastrocnemius muscle. So if you face that side wall there for me, perfect. Then you're going to just do a heel raise, so going up on your tiptoes.
Wait, 1 foot or 2 foot?
Yep, 1 foot at a time. Nicely done. And then your other one as well. Great. All right, next we're going to be assessing dermatomes, starting with the lower extremities on our patient. You're going to begin with a feathered object that can help them feel that sensation. And again, you're going to want to test both sides, making sure that they can feel the same in both the affected and unaffected extremity. All right, starting with the L1 region, you're going to swipe across that upper thigh, and then on the other side as well. And then you can ask your patient if they felt both those equally on both sides.
Yep.
Wonderful. Moving on next to L2, it will be just below L1, and again swiping.
Yep.
On both sides.
Yep.
Did that feel the same?
Yep.
Perfect. And you can ask your patient that after every single one, but we just won't document it here. Next, moving on to L3, we are going to have just below L2, moving like so on both legs. Next is L4. And L5. All right, for S1 and S2, a lot of times with patients, they can show some signs of being ticklish, so just be careful with that if you are expecting it, maybe a jab reflex or something of that sort. So for S1, and then S2, all right, now moving on to the dermatomes and the upper extremities. Again, this would be performed on both of the affected and unaffected arms, but we'll just demonstrate it on one here. First, starting with C5, and then to C6, and then flipping it over to get the other surface as well. And then for C7, and flipping it over. And then C8. And flipping it over. And then T1. And then T2. All right, now we're going to be going a little more in depth into intact and impaired findings for some of these dermatome and myotomes. So starting with T4, that dermatome, we are going to be assessing that sensation in like their upper chest to axilla down to like their bicep elbow area, making sure that they have normal sensation when being felt with like a feathered object or maybe a sharper object too. And then a normal finding would be they're able to identify if it is a sharp or a soft object, and that they have equal sensation in both of their extremities. Impaired findings would be not being able to differentiate either of those, and then maybe like numbness or tingling or pain with that as well. So starting here is my sharp object. I'm just going to show you what that would feel like. So it's not too sharp, not too crazy. I'm going to go ahead and do that on both the affected and unaffected sides. Are you able to feel that?
Yep.
What would you say that it feels like?
Sharp.
Sharp. Perfect. And then on this side too, are you able to feel that?
Yep.
Okay. And how would you describe that feeling?
Sharp.
Nice. So that would be good for the testing of dermatome T2. And then next we have the myotome L4, which is going to be dorsiflexion of your ankle. So you're going to instruct the patient to bring their toes up to their nose while you're applying downward pressure. And some intact findings of this is going to be symmetrical strength in both of the lower extremities. That would be a manual muscle test of 5 on both legs, and this would also reflect their ability to heel walk, proper gait patterns, and ability to go up and down stairs as well. Some impaired findings for L4 would be foot slap with their gait. They're not able to properly dorsiflex when they walk, maybe not able to get up and down the stairs due to some pain or fatigue with that motion as well, or maybe some hip swings to compensate for that pain and fatigue that they feel with dorsiflexion of the ankle. And then also absent strength or an inability to properly dorsiflex against our resistance. So you're going to start by asking your patient to resist the pressure that you're going to apply down on both of those lower extremities. So try to raise those toes to your nose for about 5 seconds while I push down, like so. Perfect. And with that, we had good findings of equal symmetrical lower leg strength in dorsiflexion. And then a reason for any of those complications would be because of lesions to the spinal cord nerve roots, or if there is a herniated disc in the vertebral column.